Actually, we are all hearing about the secondary glaucomas because of various reasons. And I think uveitic glaucoma is one of the very, very important cause which is to be seen while we are treating a case of uveitis. Because here it is not the glaucoma, it is the uveitis which we are concentrating upon, and suddenly we find that there is rise in the intraocular pressure. And we may miss it if we are not carefully tracking the patient. Characteristically, we call it as uveitic glaucoma, that is glaucomatous optic and neuropathy associated with ocular inflammation. But practically we see that even in the early stages, that is even in the active stage when the uveitis is not very chronic one, even then we find that there is rise in the intraocular pressure. So this definition may not fit, and practically we call all the uveitic patients with raised IOP as uveitic glaucoma. And I think uveitis is the second most common cause which is leading to a secondary glaucoma after complicated cataract surgery. There are very many reasons, and I think all the causes of uveitis can lead to glaucoma at any point of time. The risk factors for elevated IOP in uveitis patient, they are chronicity, that is when the disease increases with time, it can lead to increased IOP. Age is another factor, and corticosteroid, of course, because there are many patients which are corticosteroid responders, and we are already using steroids in a heavy dose to treat uveitis, and then activity of the uveitis. Then there is certain type of uveitis which are associated with juvenile arthritis, HLA-B27 and ANA positive. They are also prone to have secondary glaucoma. Classification of glaucoma, uveitic glaucoma, there are very many, but the important one, as also seen in the other types of secondary glaucomas, they are maybe open angle or closed angle. And why we should know the reason to increase in the IOP in the both types, because our management will depend on the way how the glaucoma has been produced. So in the open angle type, the cause for increase in the IOP is increased viscosity of the aqueous humor, obstruction of trabecular meshwork by inflammatory cells and debris, swelling and dysfunction of the trabecular meshwork, liberation of active substances such as prostaglandins and other small causes. In the angle closer glaucoma, the reason is forward displacement of the lens iris diaphragm, producing pupillary block and formation of peripheral anterior synechiae. This entity, Postner-Schlossman syndrome, I would like to highlight this because this is such an entity in which there is raised intraocular pressure, very high pressure, but the reason is iritis or iridocyclitis. So we may miss the primary disease and we may not able to treat the disease as early as possible. So the few words about this disease is that it is characterized by self-limited recurrent episodes of markedly elevated IOP with mild and AC inflammation. IOP elevation out of proportion to the degree of AC inflammation, and usually it occurs in the adults between 20 to 50 years. Many patients have systemic associated disorders, especially peptic ulcer. Here symptoms, they last for few hours to few weeks and recurrent on monthly or yearly basis. There is sudden onset of blurred vision and there is ocular discomfort and halos. The signs are mild, they are of mild anterior uveitis, but the most common, the most important sign is raised IOP, which is in between 40 to 50 millimeter of mercury. And when there are repeated episodes, optic nerve changes can occur. Here we should try to differentiate it from the fixed heterochromic iritis, because that is also seen in the same age group and many features they simulate each other. But here we can remember that heterochromic fixed heterochromic iritis, it should have a heterochromic iris, and here the KPs, they are small, white and stellate, and there are fine abnormal blood vessels on the gonioscopy. That is why gonioscopy is very, very important. And cataract is seen in almost all cases. In fact, we many times we see these cases when they come for cataract surgery. Treatment of Posner, Schwarzman and other types of uveitis, they are almost same. So we'll cover the management of all the cases. And in uveitis glaucoma management, it depends on the evaluation, because proper diagnosis is very, very important so that we can treat accordingly. And as it is important, history, symptoms, visual functions, slit lamp, gonioscopy, fundus biomicroscopy, all these things are important. But UBM is one of the tests which is becoming very popular in these type of cases. The uveitis workup, it includes investigations according to the clinical, ocular and systemic picture, and includes all the things which are important to find out the cause of uveitis. The management should be early. And why? Because early management, it prevents optic nerve damage. And the primary treatment, of course, it is medical. But as I said, if the cause is pupillary block, then laser iridotomy should be done simultaneously. And in chronic cases, surgical treatment is important. So to treat uveitis, we have to give a treatment in the form of corticosteroids, and mostly all the cases they respond very well with this. But in acute stages, we have to add, along with corticosteroids, immunosuppressives and mediatic cycloplegics. Then treatment of the primary cause is also very, very important. For glaucoma management, we have got so many drugs. Out of these, prostaglandins are not used because of the inflammatory condition, and miotics should be avoided. Beta blockers are safe. Carbonic anhydrase can be combined with beta blockers. Alpha 2 agonists, they can also be combined with beta blockers, but they are not very safe because we can remember that they can precipitate granular. So we should keep our eyes open, not from the front, even from behind also. Thank you.